We have a very interesting course on posterior capsule rupture and IOL implantation that we are going to begin soon. These will be some real challenging cases that we happen to meet in our ORs, and uh, we need to have some sort of patience to deal with these kind of cases, because many times it's unexpected turn of events that happens in the OR, and then you are often caught by surprise. But the point is that the mindset of the surgeon should be all set, and we should be ready to handle any situation that comes. So the moral of the story is that when you have these challenges coming up, take your time, be patient, learn to say no to yourself whenever it is needed, because it's not always that you keep on challenging yourself, it's also that you need to know your abilities of handling the case. So I think we begin with our first presentation. Our first presentation comes up from Dr. Rohit Om Prakash. He's a very senior consultant and an expert in handling such cases. Over to you, Dr. Rohit.
Thank you, Dr. Priya, for calling me over. It's a privilege to be here. So I would be taking up what Dr. Priya asked me to talk about anterior capsular flutter. So, basically, we all come across this situation wherein at times we have a rhexis tear and at times we end up with an Argentinian flag sign. Well, this is basically a good surgical dilemma, because at times we can complete phacoemulsification, and whereas there are other times when we cannot, and we end up in a catastrophe. So this is what the surgical dilemma is. But there is a very good silver lining, and that silver lining is that radial tears do not easily and fast become wraparound tears. So mark my words, they do not easily become a wraparound tear. Why? Because of the thickened mid-periphery of anterior capsule, and there is a barrier created by zonular anterior capsular attachment. So these two things are the positive things in it, but then that doesn't mean that we should not take care of it. Well, the first thing which you should bear in mind is no panic mode. Because what I have seen is whenever there is an anterior capsular tear, the first thing which comes in people's mind is let's convert. No, there's no need. Why there is no need? Because we have to take care of two things. First, we have to evaluate the extent of the tear. Do we have the means to do it? Yes, we have the flap motility sign. But that should not be the end of the story. This is only the first half of the story. Because if we do not adopt safe phacoemulsification techniques, we will end up in catastrophe. So that is what we need to take care of. But before we are really go into the details, I would just like you to refresh what really the flap motility sign is. Well, the evaluation of the can be made out by the flap motility sign if the anterior capsular tears are everted and fluttering. It means it's a pre-equatorial one. And if by any means it stops fluttering and it becomes inverted and then it's a wraparound tear, because it is a non-fluttering and inverted flap. What next? Well, the first thing is let's evaluate. And how do we evaluate? The evaluation is by just injecting visco, and you will see when it was injected, the flap became everted. So that is the first sign that it is pre-equatorial. Let's see it again. And when we see it again, we again inject visco and the flap is again everted. So this is diagnostic of the thing that it is a pre-equatorial flap. Let's reconfirm. And how do we reconfirm? We just put in on irrigation mode and you find, can you see the flap fluttering? This shows that it is pre-equatorial. Let's reconfirm it again in another case. Again you will find the fluttering flaps. So this shows that it is definitely a pre-equatorial flap. Next question is, how do we evaluate it, because we are busy doing the surgery? Well, there are two ways. When you are doing the surgery, you can intermittently have a look, or secondly what you can do is you can ask your assistant and tell him to have a look at the flap. And you will find that if by this method, because in our OR we have people, assistants who really let us know whether it is fluttering or not. So to really evaluate whether it is a pre-equatorial one or not. Now what is the surgical plan? The first prerequisite is have a stable chamber settings. Take care of your stepson, which happens to be the side port incision. Let it be calibrated so that we have stable chamber settings. Next is fluidics. The fluid control in the palm, what do you mean by that? It means you should have, active fluidics. Because with active fluidics, it is not a reactionary one as it is in a gravitational one. And at low fluidics, it really doesn't work. But I do not have by any means any financial interest whatsoever. Next step is slow motion phacoemulsification, as has been shown by Bob Osher and our own Abhay Vasavda. So slow motion phacoemulsification idea was conceived very much in the 90s, but it has come up a long way because with the involvement of active fluidics. What happens with this? There is an equal or minimal pressure difference between anterior and posterior segment. So that is a very important part in the whole story. So moving on next, so we have the surgical planning with us. Next is, what are the techniques? I've already talked about low IOP phacoemulsification, slow motion emulsification, stable chamber settings, because it's not that, that you go and put it on low IOP. You have to create a fluidics wherein you can have stable chamber settings and which need to be titrated as and how you move from a higher setting to a lower setting. Site of incision. Well, does it have a relevance? Yes. It has relevance in relevance to the axis of rhexis tear. Then we should create additional rhexis extensions which has been traditionally, which we all are aware of. No pushing of nucleus while trenching. Avoidance of wide separational forces. Separational forces in the direction of tear and supracapsular emulsification. So let's see these points and I'll show you how we do it. High settings. What do the high settings do? With an anterior capsular tear, chamber instability, pressure flow, it creates a situation wherein it becomes a wraparound tear. And when we use low settings, the chamber settings are there, we are not putting stress to the end point of the flap, not making it go and predisposing itself to become a wraparound tear. Low settings are very important. You should use 20 or 24, 26, but not in one go. You have to gradually graduate it in normal cases so that you can do phacoemulsification in such situations. The aspiration flow rate is around 23. So this is what, and with this, all these things which I have already talked about. Flap motility sign was published way back, we are all aware of. So safe techniques I've talked, let's see this. Now in this you will find the first thing is site of incision. Now what is this site of incision? This site of incision is not in line with the rhexis tear. So that is the first thing. So this is a good factor. And if we see the fluidics, it is around 20 IOP and 23 is this thing. No pushing, no pushing while sculpting. And the next part is, it's a hard cataract, grade 4 cataract. Chopping is there. See the direction of separational forces. The direction of separational forces are in the line, in the axis of the rhexis tear. So that is another very important factor. So this part is now continuing. Again chopping it, separating it, flap fluttering, reconfirming that it is a pre-equatorial one. Slow motion, with this amount of fluidics, you are not pushing it behind. So I'm using the Vasavda's technique and I'm debulking it. Why I am trying to take out one nuclear fragment? Because I want to debulk it so that there is less pressure on the flap end so that it becomes less predisposed to a wraparound tear. So you will see now I am doing a slow motion phacoemulsification, but at the same time you will realize that all these flaps, 1, 2, 3, and I cannot see the fourth one, they flutter in between. So this is reassuring, because at times what happens is that these two flaps are fluttering and out here one of them stops fluttering or both of them stop fluttering. So that may be a sign which we may be missing. So I'm now moving around. Now let's see what is going to happen is that I'm going to show you what I do is, So this is a very hard cataract for that matter. See, because I'm doing it slightly anteriorly and the fluidics are low, I'm placing this chopper slightly anterior to the phaco tip. Now what will that do? It is acting as a shield and it is protecting the corneal endothelium from any insult whatsoever from the nuclear fragments which would chatter and go astray and hit it. Stable chamber settings is another important thing. And the next thing which I am doing is, you will see the flap is fluttering. I'm taking out the, the cortex remnant, whichever were there, and the process is again stable chamber settings, intraocular lens implanted, trying to, make the rexus slightly bigger, and while doing stromal hydration, the flap was still fluttering. So now the next thing is, do we always succeed? The answer is no. We should know what is the end point of safe phacoemulsification. And there are conditions when the surgeon is not aware of the intricacies of all the techniques and he's not sure, and in that condition, as it always happens, he converts. So let's see in this video, the surgeon, he's trying to enlarge the rexus. In an effort to enlarge the rexus, he ended up in a situation where there was an anterior capsular tear. The emulsification is carrying on, and while dividing, the flap stops fluttering. Now what does that mean? This means this is the end point of safe phacoemulsification. So the surgeon who was oblivious of the relevance of flap motility sign continued and ended up in a situation wherein there was a catastrophe and the nucleus dropped. It is not Dr. Amar Agarwal's operation theatre where it is not a catastrophe. He would have done everything and it would have, for all of us humans, it is something which we should be aware of is a catastrophe for most of us. So in conclusion, do not panic. Evaluate the extent of the tear of the flap by flap motility sign, no endpoint of safe phacoemulsification. Site of IOL implantation is very important. Safe phacoemulsification techniques which I have already talked about. A word of caution, I have already said, all 4 flaps should be fluttering. Pre-existing PCR should be ruled out. Pre-existing PCR may give a false positive pre-equatorial fluttering and everted flaps. Posterior capsule rupture. Do I have 3-4 minutes with me? Yeah. Just let me know whenever I have to, So PCR, if it is there, what next? Let me create a situation wherein, let me show you how, if we diagnose PCR, what are the early things which we can do. This is a right eye, the patient has a fibrotic cataract. The left eye is pseudophakic with optic capture. So there might have been a PCR. That was something which was a very big deterring factor for me. Flax was done because in fibrotic cataract you want to create an intact rexus. So flax was done, a smaller rexus was created. The emulsification was started. It's a hard cataract. After creating an initial trench, the chopping was done the way Dr. Abhay Vasavda has shown, multi-level separation. So it was done to achieve total separation. Then it is in 2x now to save time. Once the chopping was again done, suddenly there is a PCR. Now the idea is, what next? Should we just pull it out as traditionally it should be, or should we go ahead? Well, there's a change in surgical plan now. What I did was, I lowered the IOP to physiological setting. I decided not to rotate it, do slow motion phacoemulsification, use IOL as a scaffold, do supracapsular emulsification, do IOL capture, and I may or may not be able to use toric IOL as it was already planned in this patient. So now what is going to happen is, let me brighten it up. We started. The first thing which I did was, I just pulled it out with the low IOP, the nuclear fragments were just floating. They were not being pushed behind. The posterior capsule was not bored out, it was not bulging. The vitreous by any means was, anterior phase was not going to be ruptured because the fluidics were going to be on the lower side. There would not be any breaking up of the interior hyaloid phase. Now again I'm caught on the wrong footing. This is a subincisional one with posterior capsule right across. You will find at this stage that there is some dimpling in the cornea. This shows that I have used low fluidics and I'm not pushing it. So what I am going to do is I'm going to use a small trick, go slow, don't push it behind, and the moment I cross it, I'll pull it up and then take it out. And then the next step would be, once I do it, I'll use IOL scaffold, which would be aptly shown as and how we go ahead in the course by Dr. Priya and Dr. Amar. And you will see now what is the advantage. It acts as a PC, the IOL. You can work at a deeper level. You can take care of the endothelium and the posterior capsule and the nucleus from going behind. And I'm doing it in a slow way. When I'm doing it in a slow way, it's just sticking to it with less fluttering, stable chamber settings, and the case was easily completed. So this is another situation where I would like to show is that, this patient had multiple anti-VEGF injections. So the visual acuity improved from 636 to 618 and dropped to finger counting in 2 months' time. So I think in this you will find so in this also the low fluidics were used, and by using flow fluidics we created a situation wherein we were able to save the nucleus from going behind and the IOL could be easily completed. So friends, whenever we have PCR, the most important thing which we need to bear in mind is that if we take care of fluidics, there are cases around when you suddenly say that I started with phaco and suddenly the nucleus went behind and there is no fault of mine. Well, the idea is at times there is a PCR with the high fluidics, with high gushing of fluid, the nucleus falls behind. Low fluidics, aptly used, can save your day. Thank you very much for your kind attention.
Thank you so much, Dr. Rohit. It was such an informative talk, and we learned quite a bit about it, like, how to go ahead. Thank you so much for it. We move on to Dr. Chitra.
Very good afternoon to one and all of you, and first and foremost, I take it as a pride to be part of Dr. Priya Narang's course, and I hope I'm able to transfer some information in the next 10 minutes. Essentially, the first one is an older video. Essentially, it's a well-dilated pupil which you're seeing here. I have got a decent rhexis. There's a suspicion that there is some kind of a polar element, but I'm able to rotate the nucleus, I'm able to chop it, and there is good, I made a trench here, but I feel that there's a red glow, but then there's followability, which means there's nothing wrong, and everything looks fine. So I'm able to easily rotate, so there's no vitreous here, no, but then stop. There is this large PC tear, and I should have stopped. I should have not gone to do complete, remove that epinucleus there. Then I've gone back and plugged that area, but there is vitreous. So now presently I would have stained the vitreous, used tricot, and then done a complete vitrectomy, then remove the cortex. Of course, there's no vitreous here because the ease with which I'm removing the cortex tells there's no vitreous. Then just enlarge the incision and I'm placing a 3-piece lens. Now I'm very foolish here, and I place a 3-piece lens in the back thinking there's enough support above and below and just one split of a PCR, and then I go behind and remove the viscoelastic and position the lens, but then the lens starts sliding, and interestingly it happened right on the table, so I could do the jugglery and immediately reposition it on the rhexis. The message here is that you should place a lens in the bag largely if you can convert it to a PCC, because that only would give the stability to the IOL sitting in the bag, but not otherwise. This is the next situation of a polar cataract. Now we all know all the tenets of the polar cataract and has those riders. So the first thing is I would want to have this PCC a little smaller. I wouldn't want it to be too large, because this could be the scaffold for placing a lens in an advent of a PCR. And then the usual mechanical delineation and the routine steps are done. it's most important that the hydrostatic pressure in the bag is retained. So every time you get an instrument in and out, or any movement, the parameters need to be low, keep injecting viscoelastic, don't allow the anterior chamber to shallow, because that weak posterior capsule can give way, and get that endonucleus out. Once that endonucleus out, you could actually do a viscodissection, because now the bulk of the content of the bag is out, and so invariably the whole epinucleus will fold on itself and come out. Sometimes it might not, you would have to do an aspiration, and I see that horizontal PCR, even after steps, I still inject viscoelastic because I would want to tamponade the vitreous, and then you can see it's a bimanual IA, and the ease with which I'm removing the cortex tells its own story, that there is no vitreous tug there. In case there was a vitreous tug, then I would have to do vitrectomy and then do an IA. But here I keep plugging that area of PC rent, and I'm able to remove all the cortex. So the anterior hyaloid face is intact. So now I balloon up the space in front of the rhexis, because that's a plan of action, to place a 3-piece IOL on the rhexis, which is being done. And the most important message is here is now I do an optic capture, and that would keep the IOL centered for any number of years, and this would have the same visual outcome as is expected of an IOL in the bag. Now this is a very simple situation, like I've nearly finished off with the nucleus, and there's a cortex there. There's a small flutter in the center of PC, which is a small PCR. Now you could convert it into a PCC, or look, I've just kept the phaco probe inside, gone through the side port, injected viscoelastic, pushed back that probable PCR from enlarging, and now itself I'm going to place an IOL in the capsular bag, which is going to act as an IOL scaffold here. So with the IOL gently tucked in so that I don't stretch the capsular bag, these are very important. No anterior chamber shallowing, don't rotate the IOL, allow the haptic to be folded in. And with the IOL pushing the PC away, I would now go in and remove all the cortex and get done with the case. This is a situation where suddenly there's an AC shallowing, there's a PCR, and I see that the nucleus is now nearly in the anterior vitreous phase. So then it does look shabby, but I go through the side ports and get this nuclear fragment up. Largely, I have got it up. So then I inject viscoelastic below. There could be vitreous there, I have not tested it. I'm just enlarging the incision, and now I would go in and place a 3-piece IOL. Now, if I'm able to visualize the rhexis, I can place it on the rhexis, or I could even place it on the iris itself. There is a lot of work yet ahead. I have to do vitrectomy, but this IOL will prevent this nucleus from dropping down, and then you would have to do a supracapsular phacoemulsification or anterior chamber phacoemulsification, but you need to just inject a little viscoelastic to coat the endothelium and try your best to do a slow, careful phacoemulsification, then go behind and remove the vitreous, come forward, inject tricot, and then any vitreous strand which is there, cut it, and then finally position it. I'm not going into all the details. Now this is a lens which is, patient has been operated 20 years back, comes back to us with the IOL not exactly in there's a PCR and a decentered IOL. So now naturally he was seeing well, but he's no longer seeing well. So I go behind and do a vitrectomy behind and front, and already it is a vitrectomized eye, but whatever vitreous which could have come forward, this again, then now I need to get this IOL out of the capsular bag. So first and foremost, I would get the haptic out, the leading haptic is taken out, and then I get the trailing haptic out. So the plan of action here is, now this is a single piece IOL. So ideally it doesn't make sense to place a single piece IOL in the bag. So either I could get the haptic out of the bag, and then with that firm hold on the haptic, I need not cut all the way through, I could just cut half of it and get the IOL out, and then inject another 3-piece IOL on the sulcus and do an optic capture. This is another situation where again a patient operated elsewhere comes to me with a decentered IOL. So I would use iris hook to just so that I get to see how much, whether the lens is broken, whether the haptic is broken. Sometimes the decentered IOLs could have had a haptic broken too. So then, but I need to do a vitrectomy. It was actually a toric IOL, but it's a hydrophilic material. So let's understand that a hydrophilic material, you need not even enlarge the incision, just hand over hand you can get it out, and then you can do a vitrectomy, inject tricot, see whether there's any remnant vitreous strands. There was a lot of it at the section, cut all the vitreous, and then go back in and inject a 3-piece IOL and again do an optic capture. Now, this is a video which I had shown in the OPL. Now, this was a high myo and a toric IOL, and a patient had been really counseled for it, and these lenses are not in a battery of lenses with you. So initially I thought it's just a deep posterior capsule, but I know in no time there is a PCR there. So I need to get this IOL position. Now, do I take out this IOL or do I position it? We all know that we would not leave a single piece IOL in the rexus, on the sulcus, but here you can see that first I'm getting the haptics out. I do a good vitrectomy, which is so very important. And then I also realized that the lens has turned upside down, so I need to tilt it and position it. And once I have positioned it, I take a quad. Now this is a deep anterior chamber, and the mid-peripheral iris, there's hardly going to be any iris chafing because of the depth of the AC. And it is only in the center part of the iris which tends to be more mobile, which could have caused pigment dispersion. So after having positioned the reading and the straining haptic into the sulcus, I again remove any probable vitreous which could have been there, and I do a gentle optic capture. Now, I have done an optic capture, and I even ensure that it is on axis. It was supposed to be on 168 degrees axis, and I see it is positioned. And it is not a temporary situation of sort. It's not that I keep doing that, but this was a kind of a situation wherein I had to take that step. And interestingly, in 3 months, 1 year now, this patient has continued to remain stable and did not have any inflammatory episode at all. Now, this is another way of bailing the situation, a polar cataract, and we do know that in a polar cataract, suddenly you could have a PCR. So you need to do adequate vitrectomy, ensure there's no vitreous. Always inject diluted tricot, 1:10 is how I would dilute it, and then check on it. And then now the plan of action again. Now again, I have challenged myself that I need to have a toric IOL for this patient, and toric IOLs come only in a single piece. So what I do is, there is fair enough space in the capsular bag. So I place the haptics, both the haptics in the capsular bag after ballooning it up, ensuring that the PC is well flat. And then what I do is, the rexus is small here. So I go behind the optic and get it out of the rexus. So now the rexus is below, there is, the lens is, optic of the lens is well centered, and the haptic is sitting in the bag. And you can see it is well aligned, and this patient also did very well. This is what I will call as a reverse optic capture. 6 weeks down the line, 6 months down the line, this patient is good. And these are interestingly 2 odd situations. It doesn't happen often enough. And if the patient is staying locally, I would remove the lens and implant another lens and explain to the patient, or do a bioptics later. This is the last of the video. Like, apparently on the surgical table, it was all done. Next day, you see that there's a small nuclear fragment coming forward. So the lens has been placed on the remnants of the posterior capsule. So in this kind of a situation, it's best to go in the pars plana route and do a complete vitrectomy. You remove the nuclear fragment, come anteriorly and do any vitrectomy of the vitreous in the anterior part, because when you do a pars plana vitrectomy, that posterior capsule will not open up larger, and you're cutting less vitreous, and you're cutting vitreous in its home. So if you were to do an anterior vitrectomy, all the vitreous would come gushing forward, and that lens would not have sat in the remnant of the PC. So this is how you need to bail out yourself. Even if you are a good anterior vitrectomy surgeon, you are not a pars plana surgeon, you could take the help of your retina person, and probably this would be the best way you could deal with in this moment. So probably the challenges of the moment teach us greater and greater learning, and this was my effort to share these few videos with you all, to just tell you the various situations where you could deal your PCRs. Thank you.
Thank you so much, Dr. Chitra, for showcasing so many videos, compiling them together for all of us. So I think the moral of the story was that, whenever you have a posterior rupture, if you have the anterior capsular rexus margin intact, it helps you a lot to handle this, for at least for the IOL implantation. Second most important thing is, learning how to do a vitrectomy. That is very important, which I will be trying to showcase during my presentation. The third thing is that, always pick up a 3-piece intraocular lens. You should always have it in your system, especially, see, complications can occur any time during the surgery, but there are certain cases where we you know, you can actually predict that, okay, this can go this way also. So for at least for those cases, we should have some lenses, 3-piece lenses handy out there. Never put a 1-piece intraocular lens into the sulcus. The haptics, they cause a lot of problem in the post-operative period for the patient. So anybody has any questions, anybody would like to ask Dr. Chitra regarding any of the points that you felt you would like to clarify or something? Okay, so nobody has it. So, okay. So, I think then we move on. Thank you, Dr. Chitra. We move on to Dr. Amar Agarwal, and he will be showing us the real-time challenging things that happens in the OR.
Thank you very much, Dr. Priya. So basically, I thought I'll show you some various scenarios. Sorry. So let's see this first case. Now you see in the case here, there was a shallow AC with small pupil. Now whenever you have something like this, the chamber is very shallow. I'm injecting viscoelastic, making my incision, but still I'm struggling. So I thought now I wanted to decompress the eye. David Chang first presented this tap technique. That means he's doing through the pars plana a vitreous tap so that in a chamber which is shallow, it will become automatically deep. So what I thought was, let me try this for him. I am passing my trocar, but look at it, I have not measured from the limbus. And when I pass the trocar, I have hit the capsule. Now you can see my capsule is already ruptured. Now I am using my iris hooks at this stage. The next step is to do my rhexis. Okay, but I know I am already in trouble. So I am doing my hydrodissection. I am trying to bring that nucleus up anteriorly, and I am doing a supracapsular phaco. At this stage, I am using an air pump to help prevent any endothelial damage. So far so good. I go in for my cortex now, okay? And as things stand, I am looking perhaps a bit lucky, hoping everything will be all right. I release the iris hooks to catch the capsule. The same iris hooks I used to catch the capsule. It's a bit tricky because the capsule can get ripped open. Once that's done, I'm able to extend inside the rhexis much easier to remove the cortex. And at that stage, I noticed that rent which the trocar had created, and you can see vitreous is in the anterior chamber. Now there's a nucleus piece also lying there. So what I'm doing is I've taken that nucleus piece and I've kept it above the iris. I can't remove it because now at this stage, if I try to remove my nucleus fragment, it will drop down. So I now take off my iris hooks. I've shifted that same trocar to infusion. Now you notice I'm fixing my second infusion trocar there for vitrectomy, and I'm doing my vitrectomy through that. Now I take my 3-piece lens and I'm implanting it in the sulcus. Once my lens is in the sulcus, now look at that nucleus. I'm going to bring that nucleus anteriorly above the IOL, use it as a scaffold and remove it. So far so good. Now the IOL is centered. I now inject triamcinolone and I'm clearing up all that vitreous, if it is anything is present. Now the problem here is I have to repair the iris. Now remember one thing, if I do a horizontal fourth row, that is from this side to this side, remember that iris which is prolapsing out will not go back. So rather than doing a horizontal, I decided let me just stop that. Instead I'll do a vertical, because that will pull the iris which is towards the incision back into the eye. So here you notice what I'm doing. I'm doing a vertical single pass fourth row. So it's very important when you have an iris prolapse coming out like that, do a vertical rather than horizontal, and that's one of the reasons why I'm showing it to you, because if you do a horizontal, no doubt you'll solve the problem, but there'll be an excess amount of iris tissue present. Once I have done this, Now you see, I'm going to do some more on the other side also. Once I've done on both sides the vertical single pass photo, my iris, you notice, is gone back into the eye. So my prolapse is got nullified. Now important issue at this stage is to check your Purkinje image. Look at the Purkinje image. I'm also checking if there's any vitreous present in the wound. And I'm going to clear up all that triamcinolone so that there's no vitreous present. Now I've got my Purkinje image there. I want to make the Purkinje image bank centered properly. So I'm just using the vitrectomy probe to make a good, nice pupil there. And now you'll see that pupil there. See the Purkinje image. All of you, when you go back, focus on your Purkinje image. This is erect. If you see an inverted Purkinje image, that is P4, fourth Purkinje image. Don't concentrate on that. This is the one you got to look at. This is without the microscope light, using an endoilluminator light only. See how it looks. Nice clean thing where you're seeing the whole eye without the microscope light on. And that's the Purkinje image. Take out the trocar. Now close up the eye. The question comes, how did the patient behave? So you can see the patient post-op 2 weeks, vision improved to 6/6. So you see in this, first the trocar hitting the capsule. Then I used it like a scaffold, the IOL, because there was a nucleus piece present there. Then I did the photoreopuplasty. And remember, when you have an iris prolapse towards the incision, instead of doing a horizontal, do a vertical. And you can see the post-op 2 weeks, vision improved to 6/6. Saying that now, I'll now move on to the next video which I wanted to show you. And you'll see that in a second here. I've started my phaco. You can see there I'm doing my hydrodissection after the rhexis. Now at this stage, I'm starting my phacoemulsification, and here very funnily, I bring the nucleus a bit out, and you can see I'm trying to continue it, and I thought I'm pretty okay at this stage. And lo and behold, you will suddenly realize while I'm performing this surgery, the whole thing broke. You see, once not only the tip broke, the whole phaco handpiece itself from the base broke. You can see that. And I think I've created some damage behind also, I'm not so sure. But normally the tip breaks. You don't see the full phaco handpiece itself from the base breaking. I've never seen that happening. You know, here you can see the whole phaco needle itself is broken from the handpiece. I had never seen this complication before, to be honest. I've seen phaco tips breaking, but here this whole thing had broken off. Now I didn't know what to do, because I was scared whether the trauma or something has happened and created a rent. I'm not so sure. So I thought, let me go in and finish my phacoemulsification. I'm removing my nucleus there, and you can see there the fragments removed. But at this stage, I'm noticing there is a PC rupture. So I do not know, perhaps some jerk has created it. A small fragment has been left behind. So I thought, let it remain behind. Let me be safe. Put the IOL inside. So all of you, if you master this scaffold technique, it will help you a lot in such cases, because now the IOL acts like a posterior capsule. Now you can go in with your phaco probe and emulsify this fragment very easily, and you can see me removing it. Now at this stage, I dilate the pupil, the iris with iris hooks, and I'm now trying to dial that lens properly and comfortably. Next step, once I have dilated it, I'll have to go in and clear it with vitrectomy probe. So obviously there is some vitreous present there, and at the same time, the vitrectomy probe, I'm going through the pars plana, and I'm going to utilize the vitrectomy probe to clear it up. A very nice thing which was shown to us by Vasavda group was how it is beneficial to use the pars plana route, which I use a lot anyway. But once that's done, always check, is there any vitreous in the anterior chamber. So I'm injected triamcinolone, clearing up all the vitreous if it is there, to check everything. Once it is removed, I inject intraocular pilocarpine to close up that pupil, and then see the pupil is looking nice. I don't need to do any phothropupiloplasty. Now let's look at one last case which I thought I'll show you, and then I'll hand it over to Dr. Priya. This particular case, you'll see just now, okay, this patient had a drop nucleus. And with the drop nucleus, the surgeon left the nucleus behind. With time, obviously, the cornea also has decompensated. So I've developed a patient with a corneal decompensation, and you can see there the nucleus lying on the B scan also. So there is the corneal decompensation occurred, nucleus drop has already occurred. So I now go inside and I make my flaps. Before that, I take off my epithelium to see better. Once my flaps are made, I am fixing a trocar AC maintainer. If you see that trocar is going in above the iris. Now once I've done that, simple trick, when you have large eyes like this, that's a large white to white more than 11, make a small peripheral iridectomy in the area of the scleral flaps. You can see I've done one on one side. This way I can come more anterior and go through the iris, through the iridectomy. Here on the other side also I've done, and you can see there I made my 22 gauge sclerotomy. Once both sides are done, I'm going to go in and do my vitrectomy there and trying to search where that nucleus piece is. And lo and behold, you see that fragment is lying in the peripheral retina. I fixed now my retina trocar and I brought those fragment to the above the disc. Using suction, I'm just bringing it up after vitrectomy. Once I brought it up anteriorly, again I will use the scaffold technique. So if you see in all the three cases, I have shown you different cases, situations where you can use the IOL scaffold and get out of mess. So once you have the IOL inside the eye, and you can just bring the fragment above the IOL, now you can very comfortably use your phaco probe and emulsify those fragments. Now remember, check inside everything is all right. Now the IOL is lying above the iris. So all I need to do is shift from above the iris to below the iris. And you see me doing that just now using the handshake technique. Here you can see from one hand to the other, catching the tip of the haptic and externalizing. Once the first haptic is out, I will do the same for the second haptic. Again, catch it anywhere. Remember one thing, you need two forceps always when you're doing a glued IOL technique, because you will use it sometime or the other. Now take the 26 gauge needle, create the Chariot's pocket and tuck these haptics inside. Once both haptics are tucked, then you are very comfortably placed, because now you have to solve the endothelial decompensation. But before that, make that pupil small. You'll see the pupil is very dilated, irregular. I'll make it a bit smaller by the single pass 4-throw pupiloplasty. So this technique pioneered with the help of Priya is something which is going to help everyone. So I suggest all of you move on to this 4-throw pupiloplasty. Once you have done more and more, you will find life very comfortable. Here you see more of the single pass 4-throw pupiloplasty being done. The advantage here is it's a very simple procedure which anyone can follow. Once you have done that, look at the Purkinje image. As I said, that's extremely important. Now you notice there's a dialysis which I've created by mistake on the other side. So I fixed a trocar opposite it, and I'm going to fix that iridodialysis. So now this is the trocar assisted iridodialysis. Ladies and gentlemen, if you know two techniques, and I repeat it again, the 4-throw pupiloplasty and the trocar assisted iridodialysis, you will cover everything in iris repair. So here you see now the second arm of the double arm needle coming out. Once that's there, I'll just pull it and tie it, and you see that iridodialysis repaired. Once that is done, you'll see that iridodialysis repaired. I now can do some more 4-throw pupiloplasty, making the pupil much better. So this is a two-fold technique where I've combined the trocar assisted with the 4-throw pupiloplasty, and you can see how the iris is now looking much better. Purkinje image is bang centered now. See that inverted image, that is the P4 which you are seeing on the top. Okay, so look carefully. That's the P1 in the center. The one inverted is the P4 image. Don't concentrate on the P4 image. Once you have done that, now I can go in and shift to air. So all I will do is shift to air, and just for completion's sake, I'll show you. I'm going to take off the endothelium Descemet's complex. We always do the PDEC technique, pre-Descemet's endothelial keratoplasty. I'm making my graft ready. Once this has got endothelium, Descemet's and the Duas layer, I will now inject it inside, unroll it and fix it. So end stage, let's see how this patient behaves at the end of the day. Remember, this patient had a drop nucleus, left behind for a long time, developed endothelial decompensation, post-operative day 1, and this is the patient 1 week post-op. So if you see in this picture, pre-op, there was a drop nucleus, we brought it anteriorly, did the scaffold, did the fourthroplasty with the Perkins image, PDEC graft injected, and 1 week post-op, patient regained paradise. Thank you very much, and once again, thank you, Dr. Priya, for this lovely course.
Thank you so much, Dr. Agarwal, for showcasing your technique. So I think one of the most handy techniques is the IOL scaffold. So coming back again to the basics is that, you need to have a 3-piece intraocular lens again into your system so that you can go ahead and do the IOL scaffold procedure, and then, after that you can place the haptics depending upon what the current situation is, whether you have an intact rexis, whether you want to place it in the sulcus, do an optic capture and all like that. So anybody wants to directly question or ask Dr. Agarwal about any doubts that you actually have? I just want to know how many of you are actually doing anterior vitrectomies whenever you have, and you are using. I see hardly, yeah, few hands are there. Thank you so much. And is there anybody who is still using those scissors to cut down the vitreous? Does anybody use that in their system anymore? I think that should be banned. Nobody should actually be doing it, because the moment you put the bud over there and you try to enroll, you keep on getting more and more of vitreous out there and trying to cut off with the scissors. No, that's abandoned. That's butchering surgery. Never do that. You all need to have a cutting vitrectomy, vitrector with you. So even if you have a basic thing like anything around even 1000 cuts per second, that works well to do the basic kind of things. Dr. Agarwal, do you have any other tips that you would like to give?
I think you're right on the vitrectomy portion. It's very, very important. All your phaco machines have got a good anterior vitrectomy system available. That should be more than enough. You don't need a posterior vitrectomy system. So I use a posterior vitrectomy, no doubt about it, but to be honest, you don't need it. If you're an anterior segment surgeon, you're very comfortable doing that. So we'll introduce now Dr. Priya Narang, who is the chief instructor on this course and a pioneer on the fourthroplasty and many other techniques.
Thank you so much. Good afternoon, everybody. So we move on to this course, and I have created some basic stuff for everybody so that there is a take-home message for everybody whosoever are interested in picking up fine points. So these are some of the animations that I have created for this. For example, this is the first one. You are doing a phacoemulsification, and suddenly, while doing, you have captured the capsule or you have a rent. So the first thing is, do not withdraw the phacoemulsification probe. It's just a jerk reaction that, okay, immediately you feel, oh, I captured the capsule, oh no, you come out. No, don't do that. The moment you do that, even if there is no rent, you will create a rent out there. You have to be into that position, go into the reflex, or if you have already created a rent, you first go from the side port incision, inject viscoelastic over the rent, and once you feel that the anterior chamber has completely inflated, then you withdraw your phacoemulsification probe, because the moment you will withdraw your phacoemulsification probe, you have a rent, your anterior chamber goes shallow, your rent becomes much more bigger than what actually it is. So this is the first basic step to do. The second thing is, like when you have a rent out there, you need to suture, take a suture at the corneal incision first, and then you go ahead from the side port incision, you use the anterior chamber fluid maintainer. Now you need to go ahead and do a vitrectomy. So whenever you have a very big posterior capsular rent, This is the ideal thing to do, which is a pars plana vitrectomy, because you need to cut down the entire vitreous from behind the rent. You don't want that thing to be coming up much more anteriorly. The same thing when you do it from anterior paracentesis, from a limbal incision, if you try to do that from a very big rent, what will happen is it will never end. You will keep on getting that vitreous coming up into the anterior chamber. So this is the best thing. Now, taking into consideration that you do not actually know how to put a trocar, so that's fine, not everybody knows it. But the point is, you just take a vernier caliper 3 millimeters from the limbus, create a sclerotomy, nothing will happen. You just create a sclerotomy. From the sclerotomy, you can introduce your vitrectomy probe, you do the vitrectomy, and then take one suture at the sclerotomy site and you are done. There's nothing much more to be done for that. So this is one of the basic things, that should be taken into consideration. But on the other hand, if you have a very small rupture which is there central, then maybe you can get away by doing a limbal vitrectomy. But the point is that you need to have a fluid infusion. Never try to do anything by injecting viscoelastic inside the eye. The more amount of viscoelastic you inject in these cases and try to cut with those scissors, things are not working for you. On the contrary, you are going to make things worse for the patient. Always stain by using a triamcinolone, because when you stain with a triamcinolone, you see the unseen things which are there. You see the vitreous much more clearly, and any minute strand gets defined very well. So this is just an animation. This is just trying to another animation which explains you how to do an IOL scaffold procedure. So you have done a capsulorhexis, you're going around doing a phacoemulsification, and then there is a capsular rupture out there. So what actually is done in this procedure, this is actually for the beginners. You take a 3-piece intraocular lens and you inject it beneath the unemulsified nucleus, the non-emulsified nucleus. Beneath that you inject it, and then what you can do is you can do the phacoemulsification of the nuclear material, and after that you can dial the intraocular lens depending upon the status of your capsulorhexis margin and support. So these were some of the basic things which I thought that let me show you. Okay, now coming up to the actual clinical cases. We have a posterior capsule rupture in this. This is the pars plana fluid infusion which is going on. There's a rent, the pupil has gone small. So the first teaching point is you need to see what you are going to cut. You cannot do anything in this small or a mid-sized pupil. To enhance the visualization, you have to use iris hooks. So now iris hooks, they work brilliantly when you have a rupture. There is nothing else that's going to work. No rings are going to be inserted because you know that there is already a rupture. Coming up to the second point is that with the fluid infusion intact inside the eye, you take up your vitrectomy probe and you try to take away all the vitreous and also the little bit of cortical matter which is there. Now the vitrectomy probe in itself will take away the minimal cortical structure which is there. It will not take the nuclear material, but it will always take away the peripheral cortical matter along with the it cuts down the vitreous, and meanwhile it keeps on taking up the cortical material also. So once you have done with this and once it has been cleared throughout, and what you see here is now a 3-piece intraocular lens. The 3-piece intraocular lens gets injected. Even if you do not know how to do a optic capture, again I would say it is fine. You can just place a 3-piece intraocular lens into the sulcus and get away with it, because it's going to remain as such, because if you have a very good capsulorhexis, it's not going anywhere. It's going to remain in the sulcus. It's not going to get any problem. Okay, but you can further improvise this by doing an optic capture. That is, it's a 3-piece IOLs. They are ideal for doing an optic capture as compared to a 1-piece intraocular lens. Because 1-piece IOLs, they are a bit difficult because there is no optic haptic, the delineation that clear. It's just a 1-piece kind of a thing. So many times optic capture becomes difficult with that, but it's simple with a 3-piece intraocular lens. So having done whatever procedure you do, when you finish off, you should know that there is no vitreous in the anterior chamber. And if it is there, you have to cut down all the vitreous which is present in the anterior chamber. Use triamcinolone as much as you want, because that's what will help you during the surgery, and even when you are finished with your case, you should know that. See, the basic is anything that does not look good if you, I mean, like when you are winding up your case and if you are still not happy with it, and if you still feel that this is not my 100%, I know this is not good, that means it is not good. It's not going to be good the next day. It's not going to happen that, okay, come on, let me see what happens tomorrow. No, nothing will happen. It will deteriorate. If you are happy settling up your case on the table, then probably yes, you have good chances. Now, these are the subluxated IOLs associated with PCR. The management of both differs. The one on one side it's a one piece, and on the other side it's a three piece intraocular lens. I have just deliberately shown this photograph because the management differs. For the one piece intraocular lens, you don't have an option. You are going to explant this intraocular lens unless and until there are few surgeons across the world who try to fix up these one piece intraocular lens also by passing the the sutures through the optic haptic junction and trying to fix them, which I personally do not believe much into it, because that causes a lot of pseudophacodonasis inside the eye. So the best thing is to get this out. But for the other one, which is a three piece intraocular lens, you still have an option out there, because you can still clear up the things, you can place it in the sulcus. If nothing works, you can also do an optic capture. If still nothing works, you can still do a glued IOL procedure or a Yamane. You can fixate the same IOL without even explanting this intraocular lens out. So these are, this was just one thing which I just thought that, okay, let me show you. Okay, now going up to this clinical case, this is the case which I did, I think, last month. So this is a case which was operated by the referring surgeon, and everything seemed quite good. But yes, this patient did have a posterior rupture, and this patient had a lot of glare, because you see that the pupil is not right, and there were some raised bouts of intraocular pressure for this patient quite often. So I decided that, okay, now this, I understood that it's a one piece intraocular lens, and it has been placed in the sulcus. So let me remove this so that, some of the bouts, whatever would have been coming, they would go away after I remove this intraocular lens. So I decided to cut this intraocular lens, but when I started cutting, I realized that, okay, no, this is not going to cut, because this is a PMMA lens. It's not the hydrophobic material. It's no way going to get cut with any of the IOL cutting scissors. So I had to, unluckily, I had to enlarge the incision a bit, and then I explanted that. And then the option was quite clear for me. Obviously, the three piece intraocular lens was taken up, and I just dialed this intraocular lens into its position. Now at this point of time, the most important thing is to take up suture the corneal incisions. 2 sutures, 3 sutures, 4 sutures makes no difference, but it should be sutured, because it should not be the leakage point of vitreous, because if the patient blinks and if there is some decompression occurring anywhere, the vitreous can anytime come up and start leaking from that corneal incision. So that has to be taken into consideration. Now the second point, I did not actually touch the fibrotic capsule as it was, because what I felt most advisable for this was that this intraocular lens is going to remain quite stable in this patient. So I just proceeded for doing a pupil repair, because there was a postoperative glare to this patient, and definitely this glare was happening because the pupil was not right. So maybe there was a struggle in the initial surgery, but anyway, we have to rectify this. So already the fluid infusion is going on. Another one thing that I would like to say is that rather than focusing on the pupilloplasty procedure, I would like to tell you that whenever we have cases like this, do not go in with a copious amount of viscoelastic being injected into the eye. With an open posterior capsule, whatever viscoelastic you are injecting inside the eye is going to go into the posterior segment, and nowhere down the, few days down the line, you are going to, the patient might come back to you with inflammation, with vitritis and all that, and it's very difficult to treat these kind of cases, and sometimes they even go into the CME, development of CME in the postoperative period. Anyway, for this patient, I went ahead and I did the single pass 4-throw pupilloplasty procedure, which is a very simple procedure which can be adopted by every surgeon who is sitting here. All that you need is a 10-0 or a 9-0 polypropylene suture, which is easily available with companies here in India itself. So if anybody is interested and they want to go into it, just let me know. I can help you around if you're interested. So this is just a single pass 4-throw pupilloplasty procedure with the suture loops going, the end of the suture, it goes around through the loop 4 times, and you then just pull both the suture ends, the knot slides inside, and you are done. Just take a micro scissors and you just cut it off the suture, and you are all set and done for the day. Again, I said I always have a habit, before I close the eye, I will always check for any vitreous in the anterior chamber. Once it is not there, it's a good sign that things are all okay. So we move on to the next video. Okay, now this is again a young case, a girl, a very young girl, 15 years old. She was doing something and then she had trauma, and then had to take her in emergency, and we did, I mean, it was all, there was no capsule or anything of that kind. I tried to retain capsule as much as it was possible, and after 2 months, we considered, when the eye had become quite, had to do this surgical procedure. Now this girl, she also developed traumatic aniridia. It was totally gone because of the wooden stick injury that had happened to her. So now, and there was also a big corneal scar out there. So I just decided that, okay, at least let me go ahead, because I know there is nothing I can do about the iris repair for this patient, but at least let me try to see if I can revive her with good vision, with the fixation of the secondary intraocular lens. So now this is a young patient. So the capsule post-operatively is so fibrotic. It's very difficult to cut it with a vitrectomy probe. You will never be able to cut. Many times even, you know, the micro scissors also, they give way. They do not, the micro scissors even do not cut it. So like, you have to do this all so patiently, and you have to devote your extra time while doing all these surgical procedures. So now what I have decided is that I'm going to do a glued secondary IOL fixation for this patient, and I have taken up a 3-piece intraocular lens, and I'm holding the tip of the haptic and externalizing the leading haptic. And now this is the trailing haptic that goes back inside the eye, and then I transfer this haptic from my right hand to the left hand, because then I need to go from the right side sclerotomy side to and hold the tip of this haptic to externalize it. And the sclerotomy sides have to be exactly 180 degrees opposite to each other. So having done this, you know, you have to be very careful. This is a handshake technique that I am doing, because I have still not got the hold of the tip of the haptic, because if I do not hold it from the tip and I hold it from somewhere else, you know, I can get a good amount of kink in the haptic, and once I get a kink, it might break any time. So then you do not have good amount of haptic to tuck into the intrascleral pockets, and this is a young patient, so I do not want to do any kind of resurgery for this patient, because this is already a second surgery that is going on for this patient. So the haptics are then tucked into the scleral pocket. So this is the max that I could do for this case. This girl, post-operatively, she is behaving very well. She has a 6/9 vision. She has a little amount. I always keep on asking whenever she comes, do you have photophobia? She never says anything, but I said, the moment you have it, you just let me know. We can, you know, give her some cosmetic lenses or something of that kind, which can help her filter the light. But currently she's just going around wearing those sunglasses kind of a thing, so that, you know, she does not, she is in a position as of now to tolerate, but I believe that it won't be much long till she can adjust to the amount of the light that's entering into her eye, but her vision is perfect as of now for this patient. So we need to rehabilitate these patients as they come into our OR. So anyway, let me show you this. This is again bag IOL complex, which was a subluxated bag IOL complex. So from the teaching point of view, I just want to highlight 1 or 2 things in this surgical video, because then again it will be the same thing. So this was a completely subluxated bag IOL complex. What I'm trying to do differently in this case is that, you know, in order to minimize the astigmatism, I'm trying to create a L-shaped incision. So this was something, I don't know if you are aware of this. L-shaped incisions were introduced quite long back, maybe in 80s or something of that kind. No, sorry, not 80s, in 90s it was reported. But I don't know why it was not much adopted, but these incisions are considered to be astigmatically neutral. You can go into the peer review and you can find out about these, how to place an incision, L-shaped incision. It's actually a 6 millimeter incision, but they are L-shaped, so, you know, you just have a 3 and a 3 millimeter kind of a thing, and the remaining 3 millimeter is an internal lip, so it's like a volvular kind of a thing, works brilliantly. So this was just a fluid infusion. This was a trocar anterior chamber maintainer. You can also use a normal anterior chamber maintainer, which is available with everybody. These are the two partial thickness flaps that I've made for this patient, the sclerotomy being made beneath the scleral flaps for fixation. So now we need to see things clearly. So now I've employed the iris hooks for better visualization, and now I will be enlarging this. So this is an L-shaped incision, which I thought maybe let me show you. So this is enlarging the incision in this eye. So the 3 millimeter of it is totally sealed inside. So I think this is the last case that I will try to show you, because we don't want to overrun this because we have other people coming in. So this is the bag IOL complex which gets easily explanted through this, and you can extend this incision internally and you can get this entire bag IOL complex outside. Many times, placing these iris hooks at the near the section, it prevents the removal of these bag IOL complex. So many times you have to release it. Release these iris hooks and then you get it, and then again maybe if you need it you can refixate them. So this is you do a good amount of vitrectomy in these patients. Always whenever there is a vitreous, the rule is do a good amount of vitrectomy. Take your time, maybe 5 minutes, whatever it is, till you are satisfied that you do not have much more vitreous coming out. And once you are satisfied with that, you can go ahead with the secondary IOL fixation of your choice. I am showing you here the glued IOL fixation. We have, but you can go ahead with whatever you like. But I think the intrascleral fixation haptic is the way to go. You can even go in for a Yamane method if you're quite confident with that. I personally, I also like the Yamane method, but the point is that we do not have those PVDF haptics out here in India as of now. So we have to use the current available haptics, which are not actually meant to do a Yamane, but still you can make a flanges out of that, but those flanges are not exactly that good and that stable as we actually want them, because having done one case with a PVDF haptic, I've realized that it's not going to work unless and until the company who makes it, they are ready to market that into our country. So anyway, these are the, and glued IOLs have always given good results in my hands. So I go ahead with the surgical procedure. So this is again fixing up the haptics from both the sides. It's always the amount of the haptic that you tuck inside makes the difference. It's not the glue. It's a misconception. Glue is only meant for sealing the flaps, sealing everything, because we know that how much important it is to seal everything especially in these complicated cases. We cannot have leakage from any point of time, because if there is a hypotony, if there is a leakage, it's going to cause a lot of problems. So that is where the glue comes in. But the strength of your lens fixation, it comes only from the intrascleral haptics that you are tucking inside. If that is well, your intraocular lens is going to remain stable. If that is not well, nothing works for you. So these are small tips that they should be taken into consideration when we have these complicated cases. So having done this and having removed all the iris hooks, and you can just reposit this inside, because with all the fluid pressure coming in, you have this iris coming in. Nowadays actually I have started if you have a case like this, where you have the floppy iris coming in, wherein because of the protrusion, I always do a pupilloplasty so that there is no optic capture in the postoperative period. Once you seal up the incision, things become quite well. The globe stability comes in and the eye looks quite taut at the end of the procedure. So you can just seal this off. I always have a habit of putting an air bubble into the anterior chamber, because it also helps me to gauge if there is any vitreous out there or not, because otherwise it would just go a bit offset. And this is how you just seal this up and things look quite good. So I think we are done with our time and we should not be overshooting with this course. So thank you so much. If anybody would have any questions or anything, you can please talk to me personally. Maybe I can answer you. We need to vacate the stage.